So good afternoon and welcome to the 8th event in Compassionate Ottawa's series on conversations with leaders. Compassionate Ottawa acknowledges that we are located on the unceded and unsurrendered territory of the Anishinaabe Algonquin Nation. We work and pay our respects to Indigenous elders, past, present, and emerging. Bonjour et bienvenue à la 8e rencontre dans la série de conversations avec les dirigeants de Compassionate Ottawa. Je suis Jim Nininger, cofondateur de Compassionate Ottawa. J'aimerais vous parler de qui nous sommes. So my name is Jim Nininger, and I'm co-founder of Compassionate Ottawa. Let me just take a moment to describe our organization. Compassionate Ottawa is a community movement that works to change the way we think about living well, dying, death, grief, and caregiving, and to strengthen the capacity of all of us to care for each other in times of serious illness and loss. We passionately believe that everyone should have the opportunity to enjoy wellness and self-respect until the end of life. In a nutshell, we are a group of some 80 volunteers working in both English and French, and in partnership with health providers, social service agencies, and community organizations to engage the whole community in caring for each other. We have a website, which I encourage you to visit to learn more about our organization. So it is now my pleasure to introduce Pam Grassau, who will join in conversation with our guest, Kerrie Noonan, who is speaking to us, as you heard, from Australia, where she tells us the temperature today is, so far in the morning, is 31 degrees, but it's above. We're a bit, we told her, in the opposite direction. So Pamela is an assistant professor in the School of Social Work at Carleton University. She also holds appointments with the Division of Palliative Care in the Department of Medicine at the University of Ottawa, and is an affiliated investigator at the Bereavement Research Institute in Ottawa. We at Compassionate Ottawa have gotten to know Pam very well, as she is the principal investigator for a 3.5-year research project called the Healthy End of Life Project, offering and accepting help, creating an end-of-life collaborative community culture. The project builds on work originally undertaken at La Trobe University in Melbourne. Compassionate Ottawa is honored to be sponsoring this public health community capacity building project, which is funded by the Mac Garrison Foundation of Canada. So Pam, now it's over to you.
Thanks so much, Jim. I appreciate that introduction, and I'm just thrilled to see all of the different people coming online and seeing the attendee list, and just really, really excited about having the opportunity to have this conversation today. I am quite thrilled and quite humbled to be introducing Dr. Kerrie Noonan as our conversation with leader person for me to connect with this afternoon. Kerrie is the director of the Death Literacy Institute, and has over 25 years, has been working to create a more death literate society, one where people and communities have the practical know-how needed to plan well and respond to dying, death, and grief. Her research and practice involve death and grief literacy, compassionate communities, and end-of-life care. She's a clinical psychologist, we were saying a social community renegade, and an adjunct researcher at Western Sydney University. She contributes internationally as a faculty member of Fellowship in Palliative Care and as a council member of the Public Health Palliative Care International. So first off, a very, very warm welcome, Kerrie. We're just delighted that you're here.
Oh, thank you. Thank you. I too would like to acknowledge the traditional owners of the lands that I'm on today here in Dubbo. And I'd just like to say, Yiridu Marang, Yurindu Kerrie, Yina, Wiradjuri, Muji. G'day, I'm Kerrie. I'm a woman and Wiradjuri friend.
Thank you very much, Kerrie. So I'm wondering if we can start a little bit with you sharing a little bit of background about yourself in terms of, you've said where you're located, but your connection to your region and community and Australia overall.
Yeah, thanks, Pam. Well, I'm in a place called Dubbo, which is about 5.5 hours from Sydney in rural regional Australia, where Dubbo is really a kind of a central hub for the west of the state of New South Wales. So yeah, it's quite a there's about 40,000 people here, about-ish, 40,000, although I think COVID, we have a lot more people out here now thanks to COVID. And there are of that 40,000 people, up to about 15% of the people who live here are First Nations, Aboriginal people. So yeah, I've been here, I came here just before COVID hit. So I'm in this interesting experience of being in a new community as a new person. And although I've been here for 2 years, I'm still kind of finding my way thanks to COVID. And so all that stuff that we talk about in compassionate communities about connecting with community and being connected, all of those things have been top of my mind for 2 years, I think.
Mm-hmm. Yeah, and it is amazing all the different layers, right, of community when you're, whether you've been in a place for a long time or a new time, the pandemic has certainly shifted so many different things. So yeah, so I appreciate you kind of giving us I wanted to ask you the other day where Dubbo was, so it's helpful to have a sense of reference points. So thank you for that. And as we talked about, we talked about that today we're going to do the life work trajectory of Kerrie Noonan. So we have this like amazing trajectory that Kerrie has taken over her time, and really are going to get into some of the key pieces and work that you've done and the learning that's come from that. But I'm wondering if you could take a little bit for those of us here in Canada that are a bit more arm's length in terms of understanding Australia as a whole country. What are the things that are important for us to know in terms of geography, population, language, diversity? You said a little bit about the diversity in your community. Like, I appreciate it's hard to speak to a whole country, so it's a hard question. But just things that would be important for us to know about Australia in terms of guiding our conversations.
Yeah, well, I guess the first thing is First Nations people have been here for 40,000 years. The land was never ceded, and that's probably one of the most important things to begin with. Australia's a new, it was colonized just over 200 years ago. So we're a very multicultural, diverse community as a whole. And certainly when I've worked in Sydney, in Sydney, we worked in some of the places where I worked in Sydney, especially Western Sydney, we would be working in a hospital environment where people, up to 70% of the people that we were seeing weren't born in Australia. They were born in many other countries, European countries. And we worked a lot with interpreters, and I think in our cities a lot of, and Australia is a very kind of coastal place as well, so most of our cities and most of our population lives on the edges of Australia, and Tasmania. Let's not forget Tasmania, and New Zealand. No, not New Zealand. Sorry to all the New Zealanders who might be here, and so yeah, there's a lot of population around the edges of Australia, and I'm not sure what else might be helpful. It's a really very diverse place, from rainforest to desert. A little bit of snow here and there. but not like Canada.
Not like we are today, yes, at least in Ottawa, yes.
Yeah, there are no frozen canals that you can go to work on. That's for sure.
Fair enough, fair enough. Some of us might want to be joining you in your pool later on. That's
Yeah.
So I appreciate that, and certainly see that there are some, some places where I think, Canada, in terms of our immigrants, in terms of our population, in terms of how our population is distributed across our country. And certainly, I'm sure there will be questions from the audience around indigeneity and how practices around end-of-life practices have really been able to embrace Indigenous knowing and values and orientation that may be quite different from medical model frames that are operating in other communities. So some of what we're going to dive into a little bit is also how healthcare is set up, because I think that's also helpful for us to have a sense of. But before we do that, given that we're focused on compassionate communities, it seems smart or important to start with community. So if you were to, and again, these generalization questions are so hard, but if you can speak to community mobilizing, like what does that look like on a kind of general level, rural, urban, what kind of mobilizing is happening around what kinds of issues? Like, what would you say around how the community works?
Yeah, in terms of community mobilizing, I would say that there's a lot of environmental work happening, a lot of First Nations work happening, and there has been a lot of activism around domestic violence and children's issues and so on. There's been a lot of, there are a lot of strong rebellious voices, I think, in Australia, and so that has been, I think, an important part of our history as well. So it is hard to generalize, because Australia is such a diverse place, and what's happening in Dubbo, for example, like all community work, I think what happens in Dubbo and what we do locally and the things that are important locally, which are, there's a lot of First Nations campaigns happening locally, a lot of healthcare. We've got lots of issues around getting good healthcare out to where we are in rural Australia. There's probably, we don't, for example, we're one of the biggest health areas in New South Wales, and we don't have a palliative care specialist.
Wow.
So our palliative care work happens via primary health care, and we have a couple of centres here in Dubbo, a couple of hospitals that have wards that have beds for palliative care in them. And we have a palliative care service, of course, which is nurse-led. We have some volunteers, but not many. And COVID has changed a lot of the volunteering because of access to place and stuff like that. So yeah, what we do here can be quite different and quite unique to, say, when I was living in the Blue Mountains, and Blue Mountains had a palliative care service and had particular things that you could access and tap into that we probably took for granted in the Blue Mountains compared to out here, for example. So yeah, I think that's one of the things about Australia and some of the research that we did as well, that while there are some common themes around kind of the way compassionate communities work happens, there's certainly the way it happens, the way that it rolls out in each community, even micro communities like a school, can be so unique to the group of people that are there. And that's good, right? Because there is no cookie cutter recipe. There's no recipe for this work. Yes, there are some broad concepts that help guide us and that are important to us, but on the ground, compassionate communities work really is hopefully responding, or the best kind of compassionate communities work is responding to the needs of that community.
Mm-hmm.
Yeah.
That's excellent. And I really appreciate you bringing it back to that local context, right? And the people in the community and the needs that are being expressed, and that really being the fuel, right? That motivates what kinds of initiatives move forward. And so if we were to take you back to some of your early work, and I feel like in that question, I'm making you out to be quite a lot older than you are, but I know you've been doing a lot of work in this area. So in terms of some of your early work as a bereavement counselor, if that's kind of, and just talk to us about what that work was, and what were some of the critical takeaways from that work that you were doing?
Yeah, well, I mean, one of the things that I often share with people, though, even before that, was that I was a volunteer. And I was a volunteer in my community as a teenager. You know, at 18, I started volunteering for Camp Quality. I'm not sure if you have Camp Quality in Canada, but it was a charity where mentors would go on camp with kids with cancer. And so I started doing that early on, and I did that for all those kind of formative early adult years, which was an incredible experience. I started volunteering then for grief groups and other groups, and learning the work of, and began my very first job out of uni as a bereavement coordinator. And I was working with a palliative care service, and that was back in like the mid 90s, and we were doing a lot of death education work in community. We were doing a lot of work with families. Yeah, it was great. And one of the exciting things for me as an early psychologist was that I was working in a team with nurses. Like, it wasn't uncommon to get in one of the cars with the primary health nurse and go out and visit a family and spend time with families. And I think all of those early experiences really were quite confronting to me, because of psychology often, well, particularly the way that I was trained, it was a very individualistic kind of view of people and communities and mental health, and the social determinants of health didn't really become part of our training, and so that I had to kind of shift that and change that very quickly. I think I remember very early on wondering whether or not I was actually, I should have done social work instead of psychology. But yeah, it was a really great experience, because it was an incredible learning experience doing that early work in bereavement. And that then led to into some research around suicide and children, and then kind of looking at I'd started to do family therapy work and train as a family therapist. I think what happened for me really was I started, in that kind of, I guess, biopsychosocial model of the individual, and just my whole career have got broader and broader and broader and broader. And now, I guess my interest is in whole populations and how we can work together, and how we can create change at that kind of population level. Yeah.
Yeah, it's beautiful, that trajectory, right? And I love the idea that the community is actually the one that had you push out, right? Like it's like we're trained in these disciplines, and yet, our actual work in the community is what pushes the social determinants of health and the need for us to be looking at social, cultural, political frames, right? Yeah.
Yeah, definitely. I mean, and the 90s were kind of post the really big kind of death education movement in the US as well. And so I think that was that kind of helped kind of frame some of the things that I was understanding and seeing in the world as well, which was really great.
Yeah, that's excellent. I appreciate you sharing that. And I'm wondering, in terms of some of the early research that you were able to get into and working with bereaved caregivers, if you can speak to some of that work that you did.
Yeah, well, so I was working for a community development organisation in 2007, and we were training mentors, community mentors, we called them, people who'd experienced caring, who'd been carers for someone caring at end of life and had that experience. And what we were doing was asking community members to come forward and train to be mentors to other carers who were going through the same thing now. And so part of my job in that role was to really to understand more about what we were doing and the kind of change or impact that was happening because of that program. And so I started, I literally Googled it, I Googled social capital and caring, and ended up at Western Sydney University with Rosemary Leonard and Debbie Horsfall. And luckiest Google ever, I think. Up until that point, we'd been looking at psychological factors, and we'd been kind of suggested to do particular kinds of research or evaluation. And I knew it didn't kind of fit. It didn't bring in the social determinants quite in the way that we were talking about it. And also, at the time, social capital wasn't really talked about in the context of palliative care, at least not in a significant way. It was more of a kind of fringe thing that people talked about, or sociologists talked about, not people in end of life. And so it was really very exciting, because what happened was Debbie and Rosemary brought the kind of frame around like social justice, and really kind of thinking about, well, how do we look at social capital in this quite particular group of carers and understand the impact of being supported through caring at end of life. So that was where the first kind of research, we did a little pilot study using Photovoice, which is a methodology where at the time, I mean, it all feels a bit quaint now, but at the time it gave people cameras, those disposable cameras. Yeah. So we'd give people disposable cameras, and we'd say, take photos of what care and caring means to you. And they would share the cameras with the people who supported them to care. And then we would bring all of those people together. So sometimes there'd be a group of 20 people, we'd turn up to a focus group, and there'd be 20 people at the focus group, all of who had supported that carer to care at end of life. And then we would draw network maps together. And we would look at how the network has changed over time for that group of people. Like in particular, we were interested in how connections changed. So we would draw these kind of amazing maps where, well, the community would draw them, where people would be able to kind of see how their relationships in this kind of group of 20 or group of 10 or group of whatever had kind of changed over time. And then we would ask them about it. They were just these most incredible. It was really like one of the most incredible pieces of research that I'd ever, been involved in, because it took focus groups to a whole other level. It took kind of trying to understand what was going on in these care networks to a whole other level. And we were really able to kind of get into some of the nitty gritty of what did people do? Because I don't know what it's like in Canada, but I imagine it's a bit similar. If you ask a group of people who have helped support a carer, so family members or neighbours and friends, if you ask them, well, what did you do? Most commonly people will say, I did nothing. I really didn't do anything. So what the photos did and what the mapping did was help kind of bring that to life in a way that people could, it made tangible for community members. It made tangible the caring experience, because if you've got pictures of cups of tea, a fridge, a toilet, shopping, a lawnmower, if you've got pictures sitting on the table while you're talking about what did you do for each other, how did you support each other, then those photos that the community took themselves are an incredible prompt for discussions about, well, what did we do, how did we support each other? So that was yeah, it was brilliant. It was amazing to see these stories of care come to life.
And every time you talk about it, you get so passionate, and it's so clear that work, and certainly in the literature, it stands out, right, as work that was really pushing our understanding for end of life, what social capital was, right? I think there are varying definitions of it, but as an abstract piece around all the relationships of care that people have, that support each other during end of life. And I'm wondering, did you find that social capital, people's understanding of social capital also deepened? So, in terms of looking back, so, what might have been people not being able to see emotional support in the same way, but in these maps, being able to see the people and the numbers of people grow. Was that part of, did you feel like the focus groups helped deepen that for them as well?
Yeah, I mean, it did, but not in the way that we as researchers or academics might talk about that. So what people talked about was we were in this together while we were caring, and we'll always have this, and we'll always have these stories, and you being here and coming, you coming here every week and making those scones or bringing that bread once a week. This was that changed everything for me. That enabled me to be able to get on with the rest of the week, because I knew you were coming. So what it did, I think, and I think that's where death literacy started to kind of really come to life for me. There was all this, there were all these kind of unsaid, undervalued, unrecognized tasks and things that people did that were coming to life in the conversations. And I still think that's one of the most powerful things about compassionate communities, is that it has the potential to bring to life the unspoken things that are happening in our community. That glue that is already there, the connections that are already there, the things that are already happening. It has the capacity potentially to bring those things to life, and to share, to have a language of sharing about how we do care is really important. So I think that for those focus groups, and we were aware as researchers, Pam, that the groups, in a way, or the carer was often using us or using this research as a way to bring those people together again. Yeah. And it was often a celebration. There was often food, there was often wine, there was a lot of laughter, there were animals, there was everything. There was everything you could imagine at these focus groups that we did. And so that was really powerful. There was a lot of agency in the, shown by these carers. So so when we started to kind of play around with this idea of death literacy, because it became clear that people would talk about care, but they would also have this profound kind of learning, or this transformational learning around death and dying. It was clear that there didn't feel like there was a term in the literature that kind of captured what we were seeing. And that's because carers and communities showed us the way, I think, with that stuff,
No, it's beautiful. And it talks about, I know in some of your work, that transformational piece, that, that sacred connection, I think, that people have with one another when someone's dying, and how that is in the bereavement language, the continuing bond, right, is that you have walked through this experience together, and that lives as you move forward. And so I really appreciate this conversation, and I'm going to move us to your time at Groundswell, because you from that work, you then with Dr. Peter Murray, a playwright, created the Groundswell Project. And I think many of us here have seen work from the Groundswell Project and have just been, it's amazing, and it's activist work, and it's in the community, and it's really pushing boundaries. And I'm wondering if you can speak a little bit about that work, and what kinds of things the Groundswell was about, and the takeaways from that.
Well, I've met Peter Murray at a chance meeting. We met at a conference, and then we had a chance meeting, and that became a kind of catalyst to share with her some of the ideas that I was having that were based on the research, but also one of the unique things I think about Groundswell early on was I was from health, and kind of came from a health background, and Peter, of course, was this playwright and an amazing artist and producer, and had done all this amazing work in the arts. And so one of the projects that I'd started to see more of was there was a theatre project from St. Christopher's Hospice that was incredibly influential to the early days of the Groundswell Project. So it was amazing to meet Peter, who was a playwright, and I had no idea about theatre really, and so the early days of Groundswell were really about practicing arts and health-based practices, community development focused, and about learning, and about iterating that learning and putting that learning into practice, and just kind of trying things out, and trying to bring a different kind of discourse, a different kind of language into talking about death, dying, loss, and grief. So there was at the time, there was a really kind of strong palliative care, a palliative care voice, or a health voice. And we thought that there might be room to play with a community voice, and that's where the arts and health became important. So that theatre project went on for many years, and continues. The teacher who ran that continues to run that, though COVID, I think, has probably changed that the last couple of years. But we did a film festival on organ and tissue donation for a few years. We did all kinds of really experimental arts and health based stuff, and we just listened a lot. We listened to what community was saying, the words that they were using, and what we kept hearing from community members, even young people, was that we don't talk about this enough, and we've got to start to change that. And and then they would tell us how they want to talk about it. And that's, I think, that the beauty of the early days of Groundswell was that we would often put that into practice. We had, because we were a small, not-for-profit, we could kind of play with words, we could play with ideas, we could put it out there on social media. Social media, feels weird to say it now, but social media was newish. using Facebook and Twitter for social activism was still growing. So we were playing around in all of those mediums as well. It was really very fast-paced, and there was so much learning involved in those early days, that's for sure. So we'd so yeah, it was and a lot of the work was based on that work, the social network work as well. So we knew enough, we were experimenting with some of the ideas like death literacy. And I can't tell you, like in the early days, that was such a challenging term for people. So we would talk about death literacy and people go, oh, what do you mean? Like, do you have to call it that? That's it's too strong. It's too difficult. But those people were often health professionals. When we went into community and we talked about death literacy, they just got it immediately. It was really interesting. So yeah, there was heaps of learning in those early days.
Yeah, well, and you can see how death literacy has woven its way through, right? And I appreciate because that's where we're going next, of course. Although I want to have also time for you to speak a little bit to your PhD, because in there, their PhD was also in there. But so we can talk about death literacy first, maybe if that feels like a good segue, and then maybe we can come back to your PhD, or do you want to talk a little bit about your PhD in terms of
my PhD was, it was, I think I didn't, like most PhD people, I didn't know what I was doing or what I was getting into really. But the thing that it ended up being was trying to understand what it's like to be a change maker or in this space. And I call those people renegades. And I ended up talking to people who were, and in the end, there were lots of decisions made all the way along. But in the end, I spoke to people who were working in the health system and in the community. And because there were clear differences in death literacy and all kinds of things in the way that they worked. And I wanted to kind of understand, if we're going to do this compassionate communities work, if individuals are going to do this work, because we are individuals that are part of communities, right? If we're going to do that and lead that work or be involved in that work, then how do we do that? How do we chip away? How do we hold ourselves as practitioners? And so, yeah, that's kind of what I ended up doing. And it was so it was there were a lot of lessons learned, but I think there was some interesting stuff just to talk about kind of community. One of the kind of big findings was that those of us working in the health system, those people working in health and in institutional settings, we're often trying to change the culture within our institution around death, dying, loss and grief. So encouraging our colleagues to be able to refer to palliative care quicker, to be able to think about advanced care planning, to be able to do this work. And then the people in community were often highly death literate and highly system aware, death system aware. They were aware of more than the health system and what the health system had to offer. And they were often supporting people from diagnosis all the way through the funeral, the burial, all the way through to the family's bereavement. So there was this kind of contrast in the way that death work, which was my kind of overall label for things, the way that death work happened. And I think that's important for compassionate communities as well. So one of the things that we need to be able to do is understand deeply where our colleagues are situated, the system they're situated in, and how we communicate about that. Because when a community member talks about community, it's often different to the way that a health person thinks about community service. You know, this is about service delivery. This is about who are my mates, my friends, my family, the people who love me. So all of that situational stuff, I think, becomes really powerful for compassionate communities, especially because, you know, one of the barriers that people often face is having to spend a lot of time with health services talking about what compassionate communities is. Yeah, you know, defining it. No, it's not the same as the palliative care volunteers. It's slightly different. Let me explain how. You know, all of that kind of back and forth. There's still, I think, a lot of work to be done around that work.
And I appreciate what you're saying around, like, knowing what health delivery is, knowing what the strengths of health services are, and also recognizing the incredible strengths of community, right? And then being able to kind of work together in that, right? So recognizing that the work of compassionate communities is embedded in the community, right? So what does that mean in terms of neighborhood mobilizing? That is quite different than a health service mobilizing around education, right? Or mobilizing around a health service. So I appreciate you teasing that out, because I think that's something that we spent a lot of time, right, in our health project too, right? Like, what is it that we're doing and how is it different? So I'm aware that questions are coming, and I really want us to move to talking about the Death Literacy Index. And you are the founder of the Death Literacy Institute. And clearly your death literacy work has come from your work in the community and the knowledge and expertise. So I'm wondering if you can walk us through a little bit around creating the index, why it's important, what are the different ways that people can use it at different levels?
Yeah, so I've already talked about the kind of research that it came from.
Yes.
The death literacy, at the Institute, we talk about the 4 aspects of death literacy. And we talk about the SEEK model, so skills, experience, action, and knowledge. That's how we kind of break it down. So when we think about death literacy, we're thinking about the skills that people have around death, dying, loss, and grief, the experiences that they've had and how they put those into action. Action is about how they do that and how they mobilize support or how they take the steps that they need to. And knowledge is that kind of, you know, that basic kind of knowledge. What do I know, or what do I need to know? And in Australia, there are things you need to know if you want to do certain parts of death, dying, and bereavement in your way. So yeah, the Death Literacy Index really came from the research that we'd done, and it was a way to try and understand some of the change that we were seeing in compassionate communities work. So the theory of it, I guess, is that if we saw death literacy from communities coming together, that it grew and people talked about it growing, then if we're doing compassionate communities work in our communities and we're doing, you know, whether a compassionate city project, then you would expect to see change around death literacy. You'd expect to see changes in the community around those 4 different aspects of learning and experience. So the index became a way to try and understand that impact and be able to contribute to the literature, I guess, from that, or contribute to the research as well around kind of change, because we didn't have a lot of kind of change measures or ways to kind of understand change in compassionate communities when we were doing the work. So that's really kind of where it came from. So the index, I won't go through all the things we did, but it's a 29 item measure and it measures, well, it seeks to kind of understand those 4 areas at a population level. So it's not for individuals, it's for doing like population-based work. So, you get the whole of Ottawa or a representative sample of Ottawa to do the Death Literacy Index, and that would be your baseline for understanding where death literacy is. So as a compassionate community, you might decide that there are particular things you're high or low in as a community. Or you might go to the community with the death literacy results and go, what do you think about this? How come we're so good at this? This bit of death literacy, where does that come from? How is it that we got so much knowledge? Or how is it that we became so good at caring? What does this mean? What are we doing? What are we doing well? Where are we maybe not doing so well in death literacy? What are the kinds of things as a community that we could build on to enable that if we want to, and so on. So the tool really is just a way in, I think, to have big conversations about how we're doing in the compassionate. It might guide our compassionate communities work, but it's kind of like, how are we doing? How are we doing around here? That's kind of the question that goes through my head when I think about the index.
No, that's really helpful. And I like the positioning around the skills and experience part, right? Of also having people assess what skills they have and the experiences they have, right? So in some of the work that I've done, there can be that looking outside for more education, right? I think when we're a little uncertain, we want other people to come in and share their knowledge, but really focusing on what you do know, right? The fact that in your community, you do have, in a group of 25, it's likely all 25 have had someone die, right? And maybe 5 of them have been at the bedside. So what are the experiences they've learned? How did they learn to connect for, and particularly within LGBTQ communities or communities that have really had to mobilize because of the lack of medical social support, right? And so mining that, right, I think shifts our focus on what we need to learn or where the expertise is.
It's such a great point. I mean, if we go in with the assumption that people already have and may well have more than us as health professionals, tacit knowledge in a particular area, or in a particular skill or knowledge about, they certainly are the keepers of their own knowledge and their own individual skills. But yeah, it's really powerful for those community members in compassionate communities to be able to really be able to then share that knowledge with their community in a way that makes sense.
Yeah. It's excellent. And I'm attentive to the fact that there are already some questions in our chat box here. So I'm going to turn it over to Paula, who I think is going to read out the questions, and we'll go from there. Thanks.
So first, thank you both so much for the conversation that we've been privileged to listen to today. This has really been truly inspiring and fascinating, frankly. And to our audience, if you have questions at this point that you would like to ask to Kerrie and Pam, please submit them in the Q&A box. And as they have indicated, we will be beginning that session now. We have about 20 minutes for questions. So the first question is, how can we inspire neighborhoods and communities to become more compassionate within a group of people who may not know each other?
Yeah. I think that's like the core of often the compassionate communities work that we're doing. So the question was, how can we encourage people to be more compassionate. Yeah. I mean, I would be looking for ways that people are already doing that together and build on that. I think if we can always start with, I mean, what does Cormac Russell say? Start with what's strong, not what's wrong. So I think in every community has strengths and has strengths around compassion. And I would want to know how the community see that already. What are their strengths? And asking them, what they would like to see more of in their community. Even just asking the question, what does compassion mean around here? What does compassion mean in your neighborhood? That's a powerful question to potentially bring around action, I think.
I think, well, it is a hard question, and I was glad you were going first. But I think for me, it's always the small things, right? It's like when you're taking in your garbage bins and your neighbor's there, you slow down a little bit and you say hello to someone that you don't know, right? Or I have a dog, so on dog walks, meeting other people with dogs, or people with kids walking their kids to school. Like, there are some naturally forming community elements, but I think it's building on the small things so that you can build enough rapport to then say, how are you really doing? And mean it, right? And mean it below the level of, I'm good, I'm going to carry on my life as the individual that's separate from you. But good in a, I care about you. And certainly if you live in a neighborhood, we have a number of widows on our street, and remember partners who used to sit on porches who are no longer there. And we'll talk about them. And just that formation, that link back to relationships provides a way in. And I think sometimes people are scared to do that. But I actually think that people are quite receptive to you remembering. And that idea of we are remembering in terms of remembering people and putting them back into the present is quite powerful in terms of care. Okay, Paula, I'm going to stop talking now.
Thank you for your answers to that question. The next one is, in your research, did you find that death was an accepted part of the journey of life and not something to be prevented no matter what, as some health systems work primarily on preventing death?
Yeah. Well, our research was with people who were caring for people who were at the end of their life. So one of the things that certainly did come to life in the research was people, in order to care and care well for someone who's dying, especially in the home, there needs to be a level of acceptance that the person is dying. And there needs to be people need to know why they're there. And in fact, some of the conversations that we had with carers were often, it was acknowledging the dying process that, we were now in the last few weeks of life, most likely, or we were now, the person was now, dying, that were actually really important for the care network as well, because the care network could shift gear. So I think for those care networks who were really had the goal of that person dying at home, they had to be direct and clear with each other about why they were there and what they were doing. And carers were super clear about the fact that they couldn't have done it on their own. So they needed their community. So I think that's where compassionate communities becomes really very important, because compassionate communities are often made up of people who have done that, who've had those conversations, those tough conversations, who have felt those gear shifts, those changes in the course of an illness, and have had to communicate about them in a very direct way to be able to get the care that they need. So it's really tough, I think, to care if you haven't had a direct conversation about that someone's going to die. So I think, there's something really beautiful about compassionate communities, because this is the importance of bringing these conversations to life. Carers sharing their stories, people not doing that thing that we do in Australia, which is, oh no, I didn't really do much. I mop the floor once a week. That we actually start to honour and really feel proud of mopping the floor once a week, really feel proud of mowing the lawn, or whatever it is that we did to turn up to support a carer. And carers, people who have been there and done that, can really bring that to life, and the importance of that to life, I think.
Excellent. Thank you so much. Paula, do we want to go to the...
Sure. So our next question asks, has there been any analysis of the death literacy indicators yet that might suggest which of the 29 might be more indicative of community capacity?
Yeah, not as far as I know, no. And so the Death Literacy Index is still a reasonably new measure, a new scale, and that work still needs to be done. And like all tools, people use the Death Literacy Index in lots of different ways, but that's something we're really encouraging people to do, to go and find out what are the important elements for communities, and what that might mean for their community. Yeah.
And some of what you had talked about too is that as the index is being translated and being made available in different places, that there's also an understanding that, some of the items may need to be shifted around language, just around what, around that context, right? So that it really is measuring what you really want it to measure at a local population level that can be compared internationally, but is still giving you data that's really situated, right?
Yeah, for sure. So so go use it. Go find out. I think it's a great question. You're thinking like, I don't know if you are a researcher, whoever asked that question, but start wondering about that, and it would be great to know, right? I suspect that one of the most valuable things that the index potentially could be is a conversation starter in communities, especially if there's been a population-based study, like we've got some in Australia, so we kind of know the baseline of where things are at. So that provides a kind of platform to have a lot of discussion about how we're doing, how a community might be doing, how a group of people might be doing. So I think out of using it and developing those questions and developing ideas around the index, that we'll start to kind of understand more about which questions matter most. Such a good question. Thank you.
Our next question says, Indigenous communities' focus is often on family and community rather than individual, many Asian communities as well. Does this help in collective support and grieving? And does it help in creating compassionate communities?
I think the answer is in the question. I think so, but I think I wouldn't want to speak on behalf of Indigenous or other kind of cultural communities, but I think there is evidence to suggest that there is a lot of there's a lot of knowledge, a lot of tacit knowledge, like practical knowledge, practical knowing in First Nations communities, in cultural groups, that often gets overlooked because it might not fit in the medical model or a health service model. And one of the things that we could do better, definitely, is seek to understand that practical knowing, that knowledge, those knowledges, those experiences, before we offer anything as a health service or even a compassionate community. So I think that's my learning around that we ought to be more curious as health professionals, as researchers, about what's known. And Mary Lou saying, Mary Lou's research. Yeah, check that out. Well, oops.
It's all good, Mary Lou. It's great that you're there, and we can certainly, provide links to your work, and as you're saying, that the First Nations communities taught you that they are already compassionate communities, and
Yes.
I would, and I would say certainly similarly, while different populations, and I certainly wouldn't want to be comparing communities, but I think in terms of our work in faith communities, they are compassionate communities. They are, meeting all of the things that are what compassionate communities are in terms of criteria. And so their work then is what does it mean to be a faith-led compassionate community, and to have mission and values around their faith, and how that faith gets enacted in a compassionate community. And yeah, so I appreciate that. So there's other questions. So I feel like I want to keep just talking to Kerrie. I feel like Kerrie and I and the rest, we could have many conversations here, but I'll turn it back to you, Paula.
Thanks, Pam. So the next question asks, can you talk about the challenges that the community faces when an individual does not want to accept help and compassion from the rest of the community? For example, they're grieving the loss of who they were before they had a baby, not a death necessarily.
Yeah, it's really tough, isn't it? I mean, acceptance is so I think the word that stands out there for me is acceptance. And I think that what to speak to around that, so many things to speak to. I'd love you to chime in as well, Pam, but what I want to say about that is that I guess we go at people's pace. And so in my experience, if I put my clinical psychology cap on now, as a therapist and as a person who works, with people who are struggling with mental illness and mental, health, it's not common for people to not accept that something is happening for them in the true sense of the word. So I think, that's why it's important, I think, not to be thoughtful about the way that we think about concepts like acceptance, and I think to not necessarily label behaviours as acceptance or non-acceptance. So in terms of compassionate communities, what that says to me is that, one, we go at people's pace, and two, we always find out what it means to people. What would it be like for someone to accept help, to have someone come and support them once a week, or what would it be like? How do they imagine that? I think about people that I've worked with in working class areas who have never had help, ever. So the idea of having a stranger come into your home And you then need to tell that stranger what to do in your house, as in clean my blinds, wash my floor, do my dishes, vacuum the floor. It's a completely unusual, strange concept to them. So sometimes we even need to spend the time, I think, understanding what it would be like for someone to have support in their home. Because what you might see might not look like accept. It might, in our lens, might look like they don't accept this is happening to them. But actually what it is I don't have yet the skills or even the concept of having people who are helpers in my house. Does that make sense? Is that helpful?
I think that, I mean, yeah, I mean, I think that makes a lot of sense to me. And I think what I also hear in that is that when we're offering help, you know, I think there's a lot of humility in that, right? And so I'm quite cautious around whether we need to move to a place of someone being accepting or not, and more just, you know, continue to open the door, right? I think that someone may not be able to talk about a loss related to what their life was before a baby, but they may tell you about their baby screaming for 6 hours last night and how they're feeling right in this very moment, right? And so find the openings, right? And trust that those openings will take you closer to the grief and loss and supports that they may need. But it does mean we need to shift how we offer, right? I think we can't move into that situation feeling like we know the help that someone needs, because until you're in that person's position, we can't possibly know what somebody would need or want. Yeah. I appreciate the question, because there are places when you're, you know, trying to offer and it's not being met, and how do you, yeah. So I appreciate that.
Yeah, and I think that one of the goals of compassionate communities is it's kind of how do we help each other around here kind of stuff, you know. So I think it speaks to a bigger issue around we are trying to change some social norms. Actually, that's really big work from a kind of a community point of view. There are norms about help, about acceptance, about you know, what you do and don't do when you're unwell or when you're grieving. And some of those norms, compassionate communities are actually kind of tweaking and nudging and changing a little. Yeah.
So we have time for one more question. Unfortunately, there are a couple we won't be able to get to, and I'm so sorry about that to those that submitted those questions. But the next question asks, was the medical community receptive to a compassionate community's approach?
So I think the medical community, in my experience, understand and really want the community to have more understanding of compassionate communities, and to, in particular, to understand palliative care and getting access to palliative care and how you access palliative care and how palliative care works in your area, and trying to prevent, you know, late referrals and trying to encourage advanced care planning and all of those times that medical or health service delivery kind of interfaces with the community. I think in my experience, the medical community have been totally receptive to that and those ideas. One of the things that can be challenging, I think, for health services, I'll talk about health services, I guess, is the which medicine is part of, is how we all work together, that collaborative piece. So who does what, and who has kind of knowledge, and what that knowledge means, and what the different kind of knowledges are, can sometimes be difficult. And I think in the early days of compassionate communities, that was more difficult, because we were often trying to meld, we were often talking about community development principles or health promotion principles, and trying to meld them with palliative care. And it was all a bit too much and a bit too difficult. So I think, so I would say yes. In my experience working with medical people, it's been a really good experience, and working with clinicians in palliative care has also been a really good experience. And it's a partnership and it's a relational thing. Actually, I think compassionate communities, if you're going to set up compassionate communities, and you would all know this from the work that you're all doing, the early kind of courtship between a compassionate community or a group of community members and the health service and the medical system, those early days are really important, and we should slow down and take time to understand what we mean by certain concepts and what that would look like, and really take time to have those cups of tea or mulled wine or whatever with each other, to really build that trust and build that social capital as we kind of move into doing more social interventions or work in community, if we're going to if it's going to be a compassionate community that works in that way. So the medical system can be great allies, are essential for this work. Yeah.
Mm-hmm. Yeah, I would agree. I mean, I think that there are some amazing public health palliative care healthcare providers in our community, in our hospitals, in our palliative care units, in our hospices, who are working fiercely to support community in the home and to build capacity in the community. And similarly, within our community, they're, bolstering the capacity of community members that's not driven by healthcare providers, but also respects the expertise that healthcare providers have, right? So it's coming together in a way that can really, you had said to me, Kerrie, when we had chatted, like really knowing each other's strengths and being able to really bolster and work together based on your strengths. But that does mean that there needs to be respect for what those strengths are.
Yes.
On both sides, right? And certainly working with social services, there are a number of people on the call from our community health centers, and recognizing that social workers and outreach workers and workers on the ground in varying programs are doing palliative care, and may not use that language, may not see that work as palliative care or even own that language, but they are the ones at the bedside. They're the ones leaving the clinic and biking over or skiing over to check on patients after hours to make sure that they're okay. So that support is happening. So it's really about bringing the systems together.
Yeah, that exploration of strengths and that acknowledgement of strengths, I think, is so powerful. Definitely. I mean, the tough thing is that for some services, or for all of us, it's acknowledging that there are certain things that we can't do that community can do much better than us, and vice versa. So really, by knowing your strengths, you can really bring all of that to life. Yeah.
Mm-hmm.
Well, Pam and Kerrie, thank you so much for your answers to those questions. And thank you to all of our audience members who asked questions today. We are reaching the end of our scheduled time. So at this moment, I would like to invite Jim Ninninger to come back up on the screen to give us some closing remarks.
Okay. And I just want to join Paula here in thanking Pamela and Kerrie for engaging in this discussion. It was riveting and a very sensitive, thoughtful, caring discussion the two of you had. And you've informed us, you've challenged us, you've inspired us, you've given a sense of how our work fits the work you're doing in Australia, Kerrie, and it was a very good conversation. So thank you very much, and thank everybody who joined us. That we had about 160 or so people registered for the session today. Someone will be watching on the YouTube channel afterwards. Thank you too, and I hope you found the conversation as stimulating as certainly as I have. Just some comments to finish up. A feedback survey will be sent to you via email tomorrow. You give us your thoughts and reactions to the session today. And a recording of the webinar will be posted on our website in the near future. And for the next session, please mark the date of February the 15th for our next conversation. And our guest will be Andre Picard, a well-known Globe and Mail journalist and author, who will be in conversation with Louise Hanvey, one of our Compassionate Ottawa board members. So mark that down as February the 15th at 10 a.m. And finally, please consider donating to Compassionate Ottawa so that we can continue to offer these conversations and our other programs. You'll find the donate button at the top right-hand corner of the website. So thank you again for your participation today. Until our next conversation, à la prochaine fois.